Respected Chairperson, learned audience, my dear colleagues, Assalamu alaikum and good morning. I am Dr. Muhammad Arifur Rahman. Welcome you to this August gathering. So, primary PCI is the selling in the storm. According to the current STMI guideline, primary PCI remains the preferred reperfusion strategy for STMI. We all know that. Timely access to primary PCI remains a significant challenge. That's why huge number of patients is out of this service. In such cases, pharmacoinvasive approach is an acceptable alternative in our country, where patient is treated with STK or tenecteplase in a non-PCI center and referred with a PCI-capable center. Nowadays, in our country, we know all TNT is available, that is metylase, and is available in all PCI-capable center and non-PCI center as well. So let's start with the case. It's a 53 years old male presented with chest pain, and ECG shows acute STMI inferior with complete heart block. And what we did, this is the clear-cut picture. So this patient has a critical lesion in the proximal RCA. And LAD also got at 80% mid lesion, LC is a 70% lesion. Just we proceed with the TPM as he was in complete heart block. We just take a floppy wire, just introduce it, and the flow established after pushing the wire. Just we take a 3x33 drug-eluting stent, and the lesion is completely clear and procedure is complete. So it's a very easy job. So after this case, our impression is primary PCI is just a fun, so easy to perform, and takes only 3 to 5 minutes. And a few cases we may get this kind of scenario. Let's proceed for the next case. How our ideas about primary PCI changes face to face or case to case. This is a case, 65 years old, presented with chest pain for 5 hours, and ECG showed acute ST elevation MI anterior. So this is the angiograph findings. He has got left main disease 60% almost. LAD also has a 60% stenosis in the mid portion. LCX has the minor plaque, but RC is totally occluded. So we also think it may be like the previous case where we introduced the wire and the flow is established. But this does not happen in this case. See, we have to try it with the regular Judkin right catheter, but we failed to get best support from it with the floppy wires. So what we did, we immediately changed our mind. As it was in radial route, we took a EVU catheter, 5 French, and as support wire, that is intermediate wire, and see how we get the support from the opposite side, and ultimately we could proceed and negotiate the lesion. And initially, as well difficulty to proceed the lesion, we took 1.5 balloon, and sequentially we rise into 2 balloon, but there was no flow after the procedure. Let's see it in the third slide. In this case, we may think there may be thromboalbumin like this, but what it did, we just proceed a 1.5 balloon the distally, and it was stuck. Then we sequentially inflate that, and after that we get a lesion in the distal part, and that was the cause of this no flow. When we sequentially dilated, then the flow was established. And what we did, we put a stent in the distal part and another one in the proximal part. Ultimately, the lesion was clear, and we put this patient for integrated for next 24 hours. So conventional it may not always work, and it may take different strategies for different cases. In some cases, we may also get the anomalous origin vessels. Let's see, here is the position of the RCA. It's a totally anomalous and just close to the LAD. When we get it, it was not negotiated with the conventional catheters, and then we again take the EVU catheters, and ultimately we could engage the catheter in the anomalous RCA. But it was difficult to negotiate this less support wire, and ultimately we could proceed, and wiring was complete. As in between, we just immediately, without no delay, just put the stent and came out from the lesion. So this is the final view. See, so it could be done in anomalous origin. We have to change the catheters, we have to change our mind, and we have to practice the different approaches. So now another case that was John was talking about the multivessel lesion. Here is the patient. He has LAD lesion 99% and LCX 80%, and RC has got 99% proximal and a 95% distal. So it's a very complex situation, and he was a guy of only 40 years old and a friend of a doctor. So we proceed with the RCA first, and see, we put a stent in the distal segment first and another one in the proximal first, and the lesion was clear. But problem was what we will do with the next lesion, as patient was on chest pain, so we decided to go for multivessel stenting. And LAD with CTO wire, initially we tried, or intermediate support wire, and with the help of microcatheter, we could proceed with the lesion, and this is the final view. So, primary PCI itself creates panic when it is a heterogeneous presentation. We don't know what we will get. It's like a magic box. Anything can come out from this angiogram view. And prediction of lesion complexity may not always possible all the time. Every case should be dealt with its own merit and time-to-time adjustment of strategies. If we preoccupied with a simple or two strategies, may not give the success. So we have to adjust the strategies time to time to get the better result. Another thing is the guidelines we have and the recent trials like the BEP trial already discussed, the complete trial, these are the trials who will help us to get the best out of the primary PCI and to provide the best service to our patient with a good result. Thank you.